I used to be the patient care coordinator of the acute medical floor, and we were trying to change the culture on the floor so we could provide better palliative care. So I was on a steering committee, and so we did some really interesting, great work. And so this is what this presentation is about. So it's going to be about a palliative care insert package that we created for our acute medical floor, as well as the resource binder that the working group created. So why did we feel the need to create a palliative care insert? Well, the palliative care insert came because we wanted to add to our regular medical chart more appropriate charting that included all of the documentation required for palliative care admissions. We wanted it all to be in one spot, easy to access, so everybody was consistently doing the same care for our patients. And why did we want the change? And it was to allow the palliative care patient and their family a better experience in the hospital. We wanted the family to have more time with their loved one instead of having to retell us their story over and over and over again. We wanted their journey to be more consistent, not as repetitive, so that we all could communicate a little bit better, so that we as the care providers knew what their journey was and how we could best help them. So what is in this package? So the acute care nurses here know it's the same package as, it's a similar system that we have for ORs. That was kind of the premise of it, that there'd be a group of papers we could pull, we could put them in the chart, and we knew that everything in that package is what this palliative patient was going to need. So there's the ESAS tool, what Dr. May and Jody's already talked about. There's the ESAS graph, there's the flow sheets, PPS tool, discharge planning meeting, discharge planning checklist, hospice referral forms, community DNRs, the SPICT form, and home and community after hours info, and compassionate leave. These were all forms that acute care didn't really understand and didn't really give to their patients. And we didn't use them very often, so we needed to make sure there was a way to get these out to the patients. The palliative care flow sheet, this is what it looks like. It's the exact same form that home and community care uses. So when an acute patient comes to the hospital, if their PPS is less than 50%, we switch to this form instead of using our acute care documentation, which isn't always appropriate. We go to this form, and then when they're transferred back home or they go back home, home and community care get the same information because this is the exact same form that they're using. So the communication from acute to home and community can be more consistent. So the PPS tool, Dr. May went over it quite thoroughly. So every chart should have one. Everybody's their MAR, their medication tools have it. They're on the floor. So it's a tool that we started talking the same language. The charting makes us chart it so that it's documented every shift. Hopefully it's helping the physicians know we're talking the same language. The family meeting checklist came out of, between home and community care and acute care, what are the pieces of a discharge of a palliative patient that we were missing? And what, most importantly, is the family the most worried about? Because really, from a nursing perspective, I was worried about their safety and their equipment and do they have all their meds? But sometimes the family's worried, how are we going to get them to a doctor's appointment? How am I going to draw up that med? Who from home support is going to come, and when are they going to come? So we created this document with the intention that the families need, that's what the big box is for, that's what the family is most worried about. So it's family centered. We want to know, most importantly, what is the family's worries, and then making sure there's check boxes so that every aspect of what this patient needs at home has gone over in acute care when they're in acute. Has occupational therapy seen them? Do they have the equipment? Do they need a bed? Have we talked to them about that? Those are the kind of things that we wanted to make sure didn't get forgotten, because quite often palliative discharges are a lot of work, and there's so many people involved in the puzzle of a palliative discharge. This was just a way of us making sure that we can do it in a safe, systematic way, that we're not forgetting any piece of the puzzle for these patients, because we don't want the family to go home and not feel supported. And then this, on the back of this form, is the discharge checklist. So you've had your family meeting. Hopefully at the family meeting, all the issues for home have been sorted out. Then each department, so the family physician has a checkbox, the acute care has a big checkbox, and then home and community care. One of the cultural changes when we initiated this on the floor was that home and community care would start doing their first home assessment while the patient was still in the hospital. We were trialing it to see if it worked, so that the first home care nursing visit isn't when they're already at home, because home care nurses have different lens to look at the patient than acute care nurses. We're worried about drugs and you know, how are we going to get them home? But the home care nurses are more worried about, like, when was their last bowel movement, and they look at it from a different perspective, and how are we going to get those pain meds, and what pharmacy, and all of that. So having the home care nurse come to the floor, do the first home care visit on the floor to mitigate any of that confusion, and to kind of iron out the things that maybe we didn't quite get right the first time. So when they do go home, it's like a fail-safe almost, so that we can make sure that we're doing it right the first time, instead of the patient going home and then home care nursing having to scramble to come up with, oh my gosh, they sent them home without something. Part of it is, like, occupational therapy needs to do a home visit for anybody going home with home support. So if the home visit was done a week ago, occupational therapy can sign off their piece, and it can be an act, like, the patient is in the hospital for a week. As we do these things, they can be checked off right away. It also is very specific what the unit clerk documentation will go to home and community care, because we were not always sending the right documents. And so it's a very specific checklist now of what exactly home and community care wanted. So the SPICT form is a form that I was not very familiar with. So it replaced the BC Palliative Care benefits form. So the physicians fill this out, but from a nursing perspective, it's just good to know that some of the benefits need to be applied for, and this is the document that the physicians fill out to get those benefits for the patients.
SPICT form no longer talks about PPS, so you can't specifically give a number. It has different diagnoses and clinical indicators of each diagnosis, and you have to have 2 general and 1 specific. I have to read it every time. It's right on this page. That's why I put it back to it. And it's very small. It's a good form in that previously the palliative benefits program was really focused on cancer, and so you got your PPS 50% or lower, and you qualified. Bang, it's easy. What it didn't look at was people with organ failure, especially, who may well have a PPS much better than 50, but their prognosis could be weeks, and then they weren't qualified. So the SPICT form is good in that. It's bad in that it's a lot more intricate and hard to fill in. You have to read it every time. At least I do.
Yeah. And it still does not cover oxygen. Really? A patient can still not be qualified to go home with oxygen. So they still need to have the ABG and qualify under medical service plan to go home with home oxygen. BC, the SPICT form and the palliative care benefits do not qualify anybody for oxygen. And oxygen is $400 a month if you don't qualify. So the other form, which was interesting to me to learn, is we put in the community DNR form, because we in the hospital use our MOST forms. But when the patient goes home, those MOST forms are not effective. They need this form filled out. If they're riding in the ambulance, this form needs to be filled out, and home and community care need this form filled out. Our MOST forms are only good in a facility, not in the community. And with the most form for the nurses, when a patient comes in and they on a previous admission have had a most form, there is that where if you've asked them, is this still in place, you can sign it, and then their previous most form could be in effect until the doctor signs it. Long as the patient, you've gone over it, at last admission you were a C1, is this still what you want? And then there's the palliative care and bereavement referral form. The other form that is in the package is the expected death at home form. This form for patients that are choosing to die at home is a requirement by law to be filled out. It is the piece of paper that stops the coroner, the police, anybody to get involved when a patient dies at home. So it's an expected death, it's at home. This gets filled out, then it gets faxed to the Stubberfields, and that allows the family just to call Stubberfields to remove the body. It doesn't get the coroner, it stops the coroner, it stops anybody from coming. So as part of this, we have an all-share drive-in acute care where all the nurses can access. So there is a palliative care folder there, and all of these forms are in that all-share drive where you can all access them and print them off yourselves if you can't find the form or a doctor's asking for it and there's not a unit clerk. So it is in the all-share drive. So the admission process would be that a patient comes to the floor, you get a report from home and community care if they're coming from the community or from your patient care coordinator. We still legally have to fill out our 48-6 assessment admission data. Hopefully, if they are a home and community care client, we can glean a lot of that information off the home and community care chart. You don't have to ask the family those 2 hours worth of questions. Try to glean it from and only ask the questions that you don't have in that chart. Because it's all about the patient's journey and trying to not have the family retell their story over and over and over again. So ESAS completed once per shift at the same time if possible by the same caregiver or the patient, of course, if the patient's able to do it. PPS to be assessed. If the patient is 50% or less, you can initiate the palliative flow chart if you feel it's appropriate. If you still want to chart on acute care charting because they're still doing lots of diagnostics and everything, that's fine too. It's up to a nurse's discretion when they flip over to the palliative flow sheet. So the discharge process for all palliative patients, we were trying to do a family meeting, which included a home and community care nurse, the liaison nurse, OT/PT, and the patient care coordinator as much as possible, and any family members that wanted to be there, and of course the physician, making sure that the discharge checklist was completed and that all the actions were completed before they go home. All the support was in place and all the equipment is in place. We kind of had that unwritten rule that we would never discharge a palliative patient home on a Friday because we all know that runs into trouble because there's no support the next day for the family if they run into trouble. So it was an unwritten rule that we were doing that, and that all the paperwork is sent to home and community care because they're gonna now take over the management of that patient and they need to know everything that we've been doing on the floor. So that, and the meds we were using, what worked, what didn't work, because they're kind of taking over the care and then the family doesn't have to explain it, right? It kind of stops that repetitive storytelling from the family. So out of all of that, because we found that the all-share drive was helpful to store all the stuff in one area, the next step was, well, the doctor's offices use these forms, nursing uses these forms, home and community care uses these forms. We need them all in one place. So as part of the project, they created the resource binder. So every unit in our hospital has them. home and community care, every physician's office in Powell River all has a binder now. And so every single one of those forms we've talked about are in here, plus many, many, many other things. So these are what the binders look like. They come with a jump drive, so all the documents are on there as well. So I'm just going to quickly go over why the binder, and basically it's just to allow for a central location in the hospital on the units, as well as physician offices where the forms can be stored. It's broken down into 5 categories: miscellaneous items, advanced care planning, forms and tools, patient handouts, and hospice information and handouts. So this is one that the GPs use. It's kind of like a, they called it is an algorithm, but one of the physicians called it their cheat sheet. They always bring it up as their cheat sheet to make sure they're doing palliative care referral process the right way. There is a table of contents. This is what it looks like in the binder. So these are just some of the forms. So the advanced care planning, this is a scripted questions for those physicians who have a harder time speaking about end of life situations. In the binder, there is scripted questions to help the physicians guide that conversation. And there is a laminated card that I hear all the physicians have in their doctor's offices as well. In acute care, we were using My Voice. This conversation starter kit has replaced the My Voice books, so that My Voice is no longer the book of choice to give patients to help with end of life and making sure all their affairs are in order. This is now the booklet.
And to be fair, this is slightly different from My Voice. This is really guiding patients on how to talk to their healthcare providers about those difficult questions that they kind of want to ask, but they don't quite know how to ask and how to start that conversation going. And the really My Voice is being replaced by Nidus.
Okay.
The Nidus website.
So there's an 11-page booklet on how to talk to your doctor and to prepare you for your physician's appointments. And then in the forms and tools, the SPICT form, which we've talked about already, the PPS, Red Cross loan cupboard form, standing orders for home and community care. So on discharge, these orders would be what the physicians could order instead of like handwriting everything out. There is a standing order for home and community care. They have their constipation medication protocols, and that was based off of the Victoria Hospice one. And then all the patient handouts. So it goes all the way down. So when death is close at hand, we have a lot of these on the floor, but if we run out of them, they're in the binder. If you need one right away, you can just print them off at the computer in the unit. I must admit, I put them in room 14 very frequently. Like, I am the one that keeps refilling it in the room so that they're always in there. What to do when someone dies, preparing for the death of a loved one, the after hours, because in our community, I don't know if you all know this, between 9, well, in our community, it's even 4:30. From 4:30 to 8 in the morning, there's no after hours home and community care nursing services available. So this, from 9 o'clock on, there's an after hours 1-800 number that families can call. 4:30 to 9, nothing. And this is a form to help families if they wanted to die at home. It just helps them keep track of all the people to phone if there is going to be a death at home if they want. And then all the hospice pamphlets are in there. And there was too many to list, which is amazing, but very good resources.